Good. So it's 1 o'clock. Welcome everybody to this week's Grand Round, where we have two well-practiced speakers lined up. And so without further ado, I'd like first to hand over to Dr. Ben Perry, who's presenting on behalf of Professor Nick Wareham from the MRC Epidemiology Unit. Ben, over to you.
Lovely, thank you. So my name's Ben. I'm a clinical lecturer in general psychiatry. You might be wondering why a psychiatrist has been asked to come and give a talk on behalf of Nick Wareham. Well, my research interest is the links between cardiometabolic and psychiatric disorders, and my NIHR-funded PhD was dedicated to that, and that I was lucky enough to be advised by Nick. So he's for my PhD. So he's asked me to give this talk today. So I'll give a talk on a case of worsening type 2 diabetes in a person who is prescribed antipsychotic medication. This is a really common case that we see every day in psychiatry, but that's what makes it so important. I'll use that case to introduce the cardiometabolic comorbidity of severe mental illness, and I'll do that through the lens of schizophrenia. I'll talk about the traditional attributions for that comorbidity. Then I'll give some updates from more recent research that suggests there might be more to the story than those traditional attributions. I'll end with some key takeaway messages explaining what we can all do about it. So the case is a patient from Nick's Wolfson Diabetes Clinic, referred from primary care in 2014. It's a 64-year-old lady with type 2 diabetes since 2002. When she was referred, she was prescribed metformin and glipizide. Her glycemic control was poor, so HbA1c was between 80 and 90 millimoles per mole. She was also hypertensive, treated with 5 agents, but didn't have a known psychiatric history at that time. Sitagliptin was commenced, a DPP-4 inhibitor, and then her HbA1c improved, come down to 54. Then there was a period over time of sort of stopping and starting sitagliptin, ostensibly because of questions about therapeutic efficacy essentially. But when she was off sitagliptin, her HbA1c rose to 93, and when she was on it, it came back down to 73, suggesting that it was having some sort of an effect. In March 2019, due to a very high HbA1c, she was commenced on insulin, and her HbA1c came down. And so she was discharged to primary care. Then in July 2020, she was admitted to Addenbrooke's with abdominal pain and diarrhea. All investigations were normal, and so the symptoms were attributed to metformin, and that was discontinued. During the admission, though, she was noted to display some odd behaviour. She was seen by the hospital liaison psychiatry team, treated with risperidone, and subsequently she was admitted to an inpatient psychiatric unit in Bury St Edmunds with a diagnosis of a first onset of psychosis. In 2021, so she was discharged from the psychiatric unit, but remains under the early intervention for psychosis team. And then in February last year, she self-referred for diabetes support because of worsening glycemic control. HbA1c had gone up to 74. And the carer, her husband, reported she is becoming increasingly worried about her diabetes, and this in turn appears to be impacting on her mental health. The diabetes team managed the glycemic control by stopping the sulfonylurea and switching to a full basal bolus regimen of insulin, and then supported dose titration. The HbA1c came down to 60. So this here is a directed acyclic graph. This is sort of an epidemiological concept. So we would draw one of these things to essentially map out a potential causal chain. And this is a really simple one that explains in a really simple way, oversimplified way, the case I've just presented. So this lady had a diabetes, and then she developed a psychiatric disorder, and that in turn made the diabetes worse. So over the next few slides, we're going to furnish this tag with more information. So through the lens of schizophrenia, and why schizophrenia? So if you have schizophrenia, you're more likely to die up to 10 to 15 years sooner than the general population. While mortality rates in the general population are going down over time, this is happening less so in people with schizophrenia. So here are mortality rates in the general population. They're coming down over time. Here are mortality rates in schizophrenia. They are sort of coming down a bit, but not by anywhere near to the same extent. So that mortality gap is getting wider. Cardiometabolic burden is the leading cause of death in schizophrenia, and it's costly. So if you have schizophrenia, there is a higher prevalence of obesity, higher prevalence of diabetes, and a threefold higher risk of death from cardiovascular disease compared with the general population. Physical comorbidity accounts for over half of the total NHS cost for treating psychotic disorders. The traditional attributions imply that cardiometabolic comorbidity arises as a consequence of schizophrenia, and there are good reasons why that might be the case. So compared with the general population, people with schizophrenia might be less likely to eat a healthy, balanced diet, less likely to exercise regularly, and more likely to be sedentary. They may be more likely to smoke and drink more alcohol, and more likely to have a disturbed sleep. And of course, all of these things are important cardiometabolic risk factors. And once someone is diagnosed with schizophrenia, someone like me is more than likely to prescribe an antipsychotic medication to treat the schizophrenia. While we want the antipsychotics to work on a dopamine D2 receptor, they don't just work on that receptor. They're not clean medications. They have effects on CNS serotonin, noradrenergic and histaminic receptors, and that can change appetite. They have direct action on pancreatic beta cells that can lead to changes in glucose-insulin homeostasis. And essentially, they lie on a spectrum of cardiometabolic risk. So while some antipsychotics have less effect on cardiometabolic indices, lots of them have a substantial effect on cardiometabolic indices. And those cardiometabolic effects can occur very quickly, i.e. within weeks of being prescribed one of these medications. Healthcare inequalities and diagnostic overshadowing are really important. So people with schizophrenia attend primary care less often for physical health checkups compared with their general population counterparts. When they do attend, clinicians commonly attribute symptoms and behaviours to the mental disorder rather than a possible physical illness, leading to inadequate assessment and delayed treatment. For example, in one hospital, amongst admissions for ischemic heart disease, people with schizophrenia were half as likely to be recommended for surgical intervention compared with the general population. And amongst people with a diagnosis of type 2 diabetes, people with schizophrenia were half as likely to be offered referral for specialist care. So here is a DAG summary of the last few slides, those traditional attributions for shortened life expectancy in schizophrenia. You develop schizophrenia, and then factors related to that illness, things like smoking, physical inactivity, diet, and health inequalities, and being prescribed antipsychotic treatment, they lead to a higher risk of cardiometabolic disorders, and that leads to premature mortality. But more recent research is beginning to suggest that relationship actually might be more complicated. Early markers of cardiometabolic dysfunction are detectable from the onset of psychosis in young adults. So the peak age of onset of psychosis is between the second and third decades of life, late teens, early 20s. Essentially, these are case control studies in a meta-analysis of individuals with no prior antipsychotic use, and rates of insulin resistance, impaired glucose tolerance were much higher in cases than in controls matched for BMI, sex, and ethnicity. Essentially, what this is saying is that antipsychotics are unlikely to be the full explanation to what we're seeing, and actually the direction of association could be reversed because these things are associated with each other right at the onset of illness. And it's not just glucose-insulin homeostasis. Other groups have shown that this extends as well to cholesterol and triglyceride levels. The issue is with these studies, so most of the studies that have examined this is that they're all most of them are case control in nature. And the problem with case control studies, the same as cross-sectional studies, is that the exposure and the outcome are measured at the same time. And if we're interested in the direction of association and whether actually it could be the other way around, we can't tell with a cross-sectional or case control study because the time points are the same. The exposure is measured at the same time as the outcome. So it could be either way around. What we need is longitudinal studies where this is measured first, and then we look at this later. So during my PhD, that's what we did. So we looked at the Ausbach birth cohort. So it's 10,000 participants in the Ausbach birth cohort. We looked at fasting insulin levels in that group between ages 9 and age 24. And then we did a statistical technique called growth mixture modeling. And what that does essentially is tracks trajectories of change in a continuous marker. So here, insulin. And then it groups individuals together who have similar trajectories of change in that marker. So this is on a Z transform scale. So here is the mean at 0, and these are in standard deviations. We can see that most people, about 80%, their insulin levels remain around the mean, about average, as you would expect. There's a smaller group, about 18%, 17%, whose insulin levels increase gradually through childhood and adolescence. And there is a smaller group here, about 3% of the Ausbach population, whose insulin levels are much higher at age 9 and remain persistently high through adolescence into adulthood. We found that persistently high insulin levels, this group here, was significantly associated with all measures of all psychosis spectrum outcomes by age 24 in the Ausbach cohort, but not with depression. So essentially, this suggests that subtle alterations to cardiometabolic function could be detectable years before the onset of psychosis. Interestingly, those in the persistently high insulin group, this group here, had higher perinatal stressful life events and were generally smaller for gestational age, suggesting that early life stress might be important here. However, longitudinal studies and all observational studies for that matter are at risk of confounding. So we could summarize the previous slide with this simple DAG. We found that cardiometabolic dysfunction may precede the psychiatric disorder and so could be a risk factor for it. However, there are many other things that could both increase the risk of cardiometabolic dysfunction and a psychiatric disorder. And some of those, like diet, obesity, sedentariness, and physical illness, we can adjust for. We know about them, we measure them in a study, we can adjust them so they don't affect the results. However, there are lots of things that we don't know about or we can't measure, and that becomes a limitation for all observational studies, that they're at risk of confounding both from things we know about and things we don't know about or can't measure. Enter Mendelian randomization. So the best way in biomedicine to show cause and effect is through a randomized controlled trial. If you have a big enough sample and representative enough sample, and then you split them randomly into 2 groups, the balance of confounders, those things we know about, and the things we don't know about, should be even between those groups. And then if you give an exposure or an intervention to one of those groups, you can compare the outcomes and you can attribute any differences in outcomes to that exposure because everything else is equal. In Mendelian randomization, it leverages the random assortment of alleles that happens. So in that random assortment of alleles, if we know a particular genetic variant is strongly associated with a modifiable exposure, we can use that genetic variant as a proxy for that exposure. And then we can leverage results from very large GWAS studies, genome-wide association studies, and we can examine for differences in outcomes for people that have that genetic variant compared with people that don't. And then we can attribute any differences in outcomes to having that genetic variant and therefore that exposure. So we used Mendelian randomization to examine whether cardiometabolic dysfunction could be a potential causal contributor to a higher risk of schizophrenia. So, and then we also wanted to examine a hypothesis of whether inflammation could be a common cause or a mediator in that relationship. So what we did first of all is we examined for any evidence of potential causality between 10 cardiometabolic traits and schizophrenia, and we didn't find any evidence of causal evidence for cardiometabolic traits on schizophrenia. However, when we looked at genetic variants that were both strongly associated with a cardiometabolic trait and also a measure of inflammation, we saw something different. We saw a strong association between high insulin, high triglycerides, and low HDL with schizophrenia. And this really is known as an insulin resistance phenotype, suggesting that inflammation could be a common cause for comorbid schizophrenia and insulin resistance. To further test that hypothesis, we then used multivariable Mendelian randomization, a bit like a multivariable regression analysis, to adjust for inflammation. So we adjusted those genetic associations for genetic associations with CRP, common inflammatory marker. And when we did that, we found that those strong associations attenuated to the null, suggesting that inflammation is likely to be the cause of these associations. So here is an updated DAG summary for what I've just spoken about in the last few slides. So it's likely that common biological processes which may involve inflammation, which could arise from genetic influences and or environmental stress, leads on one hand to disrupted glucose insulin homeostasis, and on the other hand, in these affected individuals, schizophrenia, high risk of schizophrenia, then through those traditional attributions like diet and lifestyle, antipsychotic medications, that accentuates this inherent cardiometabolic risk in these individuals, predisposing to a higher rate of cardiometabolic disorders, and together this leads to premature mortality. What can be done? We need to revisit those traditional attributions that I spoke about at the beginning. Those traditional attributions, things like lifestyle factors, medication, healthcare access, they're vitally important because they're malleable treatment targets to limit the impact of cardiometabolic morbidity and mortality in these patients. Prescribed smoking cessation and exercise interventions have shown real promise in reducing cardiometabolic burden in young people with psychosis. However, similar interventions have shown limited efficacy in older adults with chronic schizophrenia, suggesting that early intervention is key. We need to intervene early before those sort of chronic lifestyle behaviours really become so finely ingrained. Trials of metformins and statins have shown good efficacy for treating cardiometabolic disorders in people with psychosis, and actually evidence from whole population studies, so for example, 2 studies, one in Sweden and one in Denmark, suggests that repurposing of these drugs could improve both physical and psychiatric health. So what are the take-home points? People with schizophrenia have a substantial burden of physical comorbidity, and you will come across these people on your wards, whatever they come in for. Whatever they are in for, this is a critical window of opportunity to take a look at their cardiometabolic health. If you see a drug chart with olanzapine, quetiapine, risperidone, and clozapine on it, whether there is a history of schizophrenia or not, think cardiometabolic assessment. Look at blood pressure, look at BMI, look at HbA1c, lipids. Consider appropriate treatment and onward referral. Don't assume that the GP will be doing this, because these patients may be attending their GP less often than one would expect or would hope. Hospital liaison psychiatry services will gladly offer advice and help for inpatients, but to be honest, there is much more to be done toward more joined up thinking in outpatient departments. So that's me finished. I'd like to thank my supervisors, advisors and collaborators, particularly Prof. Nick Wareham, for inviting me to give this talk today, and I'll hand back to the chair. Thank you.
Oh, thank you very much, Ben. That was a really clear and well-delivered presentation with lots of educational messages in, which I hope everyone is listening carefully to. I'm sure there will be a wealth of questions. Please, if you could put those in the chat, that would be very helpful. The first thing that pops into my mind is how early on in this lady's life was there in fact mental ill health, because it seems that it became overt quite late on, and yet her diabetes had been there for quite a long time. If people look back at her, was she odd? Was there any more in the history that would help you?
Yeah, so she didn't have a psychiatric history at all before this Addenbrooke submission. Whether there may have been an underlying psychiatric disorder, it's possible. So as I mentioned, the peak age of onset for psychosis is generally late teens, early 20s, but it's not unheard of that psychosis can present later in life, particularly in women. There is a bimodal distribution for psychosis incidents. So it is possible that psychiatric disorder could have preceded the diabetes, but it wasn't recorded anyway.
And maybe just to add, I think one of the reasons Ben stressed the variability in this patient's HbA1c and the question mark about the efficacy of the DPP4 inhibitor was possibly that was a clue about some behavioral challenges, because she may or may not have been taking the therapy. I have to say we didn't clock that at the time, and it's the psychiatric diagnosis only became apparent quite latterly, as Ben suggests.
Yeah. Okay. So Dr. Horan is asking what concerns there might be about interactions between antipsychotics and the medication for cardiovascular disease that these patients may need.
I think that's probably a good point. I think studies of those agents, things like metformin and sort of oral hypoglycemics, trials of those in people with schizophrenia are really in their infancy, to be honest. So actually, those interactions haven't been studied in great detail. I think theoretically there could be a concern. However, there have been studies that show that have therapeutic efficacy in people with schizophrenia, and if they may limit the impact, the cardiometabolic impacts of common antipsychotic medications, then I think that would be a great thing.
Okay, and there is a comment that long QT is everywhere, and that is something that we do need to take seriously, isn't it? Long QT syndrome,
Okay, yeah, I mean it is a potential impact of some antipsychotic medications, not others, but yes, I mean all patients generally, all patients, not generally, all patients should have a full cardiometabolic and physical health assessment before they're prescribed antipsychotics, and that would include an ECG, and should then be followed up. So nice guidelines say these patients should be being followed up each year by their GP. Unfortunately, as I mentioned, these patients generally may well attend their GP less often than we would like them to, unfortunately.
Okay, and Dr. Fistine asks, should we be considering even earlier interventions, in other words, preventing early life stressors to prevent both cardiometabolic disease and serious mental illness?
It would be a great thing to test, difficult thing to get funded. But a wonderful thing. I think that would be, yeah, I think that would be what if I could do one trial with if I had unlimited funding to do one trial, then that would be the trial to do. Absolutely.
It does beg the question, following the pandemic and its effect on children, what the landscape is going to look like 20 years from now.
Absolutely. I agree.
So do you think anti-inflammatories should be a standard part either of type 2 diabetes treatment or early treatment in mental ill health?
So I might hand over to Nick to talk about the former. I can talk about the latter in terms of the psychiatric disorders. So there are a number of trials of anti-inflammatories in schizophrenia. Unfortunately, they haven't. The results have been less than impressive compared to the observation, the whole wealth of observational and Mendelian randomization research of inflammation, of the relationship between inflammation and schizophrenia. However, there are limitations with those studies. So, for example, they've generally recruited people with chronic schizophrenia. They haven't looked at baseline levels of inflammation, because inflammation may not be relevant for all patients with schizophrenia. And so future trials might, for example, only include patients who have inflammation at baseline for those trials. And there are now ongoing trials where some of those limitations have been taken into account. But there could be a future, I think, where anti-inflammatories are used more often in schizophrenia.
Nick, do you want to add anything to that?
Yeah, I mean, I think the whole question of inflammation and anti-inflammatory therapy in type 2 diabetes is quite controversial. I mean, there are clearly some links. I think part of the problem is type 2 diabetes is not a singular disease, and that probably the way forward lies in segmentation and stratification of that into etiological subtypes. And I would have an open mind about there may be a subtype in whom an inflammatory process is more prominent, and therefore anti-inflammatories may play a bigger role. I think it is possible.
Okay, thank you. Obviously, that's quite a big question that could demand a discussion all of its own. Yeah. Nicolette has asked, would patients with affective psychosis have the same risk of cardiometabolic disorder or only those with schizophrenia?
So I think much of my research, as I mentioned, could apply to many mental disorders. So I've focused on schizophrenia in this current talk, but there are very strong cardiometabolic associations for all mental disorders. Affective psychosis or affective disorders in general also show strong associations with cardiometabolic disorders, although the sort of pattern is slightly different. There seems to be a stronger association with adiposity related cardiometabolic disorders in depression and affective disorders, whereas a stronger association with glucose insulin dyshomeostasis in psychotic or non-affective psychosis. But I mean, essentially, you know, whether you have an adiposity related cardiometabolic disorder or a glucose insulin related cardiometabolic disorder, they both predispose to the other one. So essentially you end up with a higher risk of cardiovascular disease and those endpoints in all psychiatric disorders.
Okay, you've shone a very good spotlight on the possibility of unconscious bias in how we manage such patients. In terms of the secondary care that they're offered. But John Firth has raised the point that in the acute situation, we aren't really equipped to follow up, and what the best way to mobilize primary care might be in these sorts of situations. And then there is a little debate going on in the chat as to how that might be achieved. What are your thoughts?
Yeah, sorry, I haven't had time to read the points, so these may have been mentioned, but yeah, I mean, I think it's not just about mobilizing. It's about I mean, there are lots of things really, and I think a lot of it is about making services more accessible for patients. So I think really we need to speak to our patients to find out why they're not attending. So, for example, I mean, if you have schizophrenia, your whole life is likely to be affected. Work and financial prospects, prospects of relationships, both with friends and family, and romantic relationships. Your physical health might be the last thing on your mind. So really, it's about how do we empower patients, these patients to see their physical health as important as all of this other stuff that's going on in their lives. So it's not necessarily the fault of primary care. It's just how do we deliver services, and how do we educate patients to help them see their physical health as so important, particularly in younger people who, you know, if you tell someone, you know, you've got a higher risk of diabetes and 10 years down the line, and a higher risk of cardiovascular disease 20 or 30 years down the line, it's hard to see that as important as what's going on in that person's life at the moment. So it's about how we do that and how we convey that message. So it's on us really, as much as it is on primary care.
Okay, and a related point is about weight gain in some but not all patients on antipsychotic medications, and what is known about why there is a difference among patients.
Yeah, definitely. I think this is a really interesting point. So I think it's likely that so at the moment, when someone attends for a physical health assessment before they're prescribed an antipsychotic, there is no way to determine whether someone might be insulin resistant at baseline, because there's lots and lots of research that suggests that actually people with first episode psychosis who are insulin resistant are unlikely to show that with a raised BMI. They're likely to have a higher to normal, but a BMI within the normal range. So we don't know if these people are insulin resistant at baseline. If they are, these people are the ones that are likely to be putting on weight when they get antipsychotics. If we could have a better measure at baseline of determining whether someone might be insulin resistant at baseline, we might be able to direct those treatments in a more informed way to reduce the risk of weight gain with all antipsychotics. But I think that this is research for the future really, and there is a lot of interest in this field at the moment, predicting weight gain.
Great, and there's obviously a lot to be done. And as a final question, do you know if identifying and treating the cardiometabolic disease early has any impact on the progression of acute to chronic schizophrenia?
Yeah, again, I mean, this is a really fascinating question. Something this is where research will be going, I think, in the next 5 to 10 years to look at this. It's not been looked at yet, but so I did mention there are some really interesting whole population studies in Sweden and Denmark that have shown that people who are first hospitalized with schizophrenia and depression, for that matter, who were then prescribed something like a statin or metformin, afterwards, they have lower rates of rehospitalization for psychiatric disorder afterwards, suggesting that actually that treating this cardiometabolic disorder may actually have an impact on their psychiatric health in the long term. But it hasn't been tested in a trial, but it's something really interesting to think about, definitely.
Great. So that brings us to 1:30, and I can see that you have a whole career's worth of future research ahead of you. Thank you very much again for an excellent presentation and for great questions coming from our audience. And now for something a little different, Dr. Wen Soon is going to be presenting a mystery case on behalf of Dr. Mukhtar from Acute Medicine. Wen, over to you.
Thank you very much, Professor Garrett. I will just share my screen. So, good afternoon, everyone. My name is Wen. I'm one of the IMT trainees here at Adam Brooks. And I have done this case in collaboration with Dr. Omar Mukhtar, one of the consultant physicians. And it's called The Droids Come to the Rescue, and a particularly interesting case, which I'm sure many of you in the audience have probably met as well during my hospital admission. So to take you right back to the beginning, this is a 60-year-old Caucasian female who at the time was working as a senior scrub nurse, I believe, at the Spire Hospital. Of note in her past medical history, she has had 2 children with 3 miscarriages among them. She's had a bit of tenosynovitis.
Wen, can I just stop you there for a second? Can you just make sure that your microphone is where it needs to be, and because you're a little bit fuzzy to hear.
Okay, I might just plug in some headphones to make myself a bit clearer.
Sorry to disturb.
Is that a bit better?
That's clearer, yeah.
Okay, great.
And just speak up, that'd be lovely.
Will do, yeah. In the 60-year-old Caucasian female, in a past medical history of note, she's had 2 children, 3 miscarriages, a couple of urological and gynecological surgeries, and most recently, she had had a BSO due to a persistently raised CA125, which eventually turned out to be non-malignant. So after her first AZ COVID vaccine in January of last year, she experienced some side effects, which is not uncommon, but her particular side effects wasn't very typical compared to the usual pain in the arm and a feeling of malaise and myalgia. She had pain and swelling of her hands, wrists and elbows, with her metacarpal phalangeal joints particularly affected. She had morning stiffness, which seemed to improve as the day went on, and her symptoms all affected her dexterity, and her fingers were becoming very swollen, so she had to remove her rings. Blood tests at the time weren't very particularly remarkable, ESR of 36 and a slight rise in her platelet count. And she had a normal hemoglobin, a normal white cell count, uric acid, and she was negative for rheumatoid factor, ANA, and anti-citrullinated protein. She had a subsequent improvement and resolution of her symptoms as time went on. And then after a second dose of the vaccine, she had the same symptoms which recurred, but now it is spread to her ankles and her feet. Gripping a steering wheel became very difficult. Her feet were very swollen, and now the pain and dysesthesia was really affecting her sleep. She was commenced on naproxen, and she was booked in for intra-articular steroid injections. Now, before she could attend, she then presented to her GP again in May of 2021 with proximal upper limb weakness and pain and weakness also affecting her ankles. However, her hips and her true shoulder girdle was spared, and the ESR had gone up to 86. At this point, the GP had diagnosed her with presumed polymyalgia rheumatica, which would not be uncommon in someone of her age and with her symptoms. And with steroids, this seemed to improve her symptoms, but in anticipation of an MRI of her joints, she was weaned down on her steroids, and this meant her symptoms returned with a vengeance. By June and July of last year, she was really struggling, and again she presented to her GP, and incidentally or not, she was found to have deranged liver function tests. A referral was made to hepatology, who felt, given that their acute and chronic liver panel and screens were all negative and her ESR had reduced, and given the improvement in her LFTs, this may have been vaccine-related hepatitis, but the time frame didn't quite fit. She then developed tingling in her hands and her feet, particularly among the palms and her soles, as well as a bilateral carpal tunnel syndrome. Interestingly, she was Tinel's negative at the time on examination by her GP. On referral to neurology, it was difficult to deduce whether it was the pain affecting the weaknesses in her hands and her feet, or whether it was a true weakness. So it was recommended to increase her analgesia with an attempt to evaluate for the weakness once significant pain control was achieved. And then in August, she was seen in a rheumatology clinic where she was found to have a burning pain in her fingers and a non-dermatoma paresthesia of her fingers as well. She was really struggling at this point to function, and it seemed that she had pretty much taken a medical retirement at this point. She was rolling out of bed and almost requiring a wheelchair for long distances or when outdoors. Her hands and feet were extremely sensitive to touch and were globally swollen. However, there was no evidence of an autoimmune connective tissue disease or significant fibromyalgia trigger points. And the thinking at this point in rheumatology clinic was it was potentially an inflammatory osteoarthritis of the hand with some very non-specific changes, which may have been due to a mixed connective tissue disorder. An MRI of her left hand was done, and it seemed to be the left hand which was most affected at the time, which only showed some radiocarpal, midcarpal, and thumb carpal metacarpal synovitis. Finally, there were some positive blood tests. She was positive for anti-TH and anti-TOE, which is typically associated with systemic sclerosis. However, her symptoms didn't really seem to fit that of scleroderma. And her urine dip at the time showed only 1+ for blood and a trace of leukocytes. Everything else appeared to be normal. But clinically, she was getting worse and worse. By September and October, this was when she presented in early October with 3 weeks of ongoing diarrhea, which was non-bloody, and she had originally attributed to potentially a meal of fish which had gone off. She also had a vesicular abdominal rash, which on examination by the neurologist was found to be in a T10 dermatomal distribution, which is suggestive of shingles. So she attended A&E with these symptoms as described, very, very poorly. However, her vital signs on admission were fairly unremarkable. The CRP had now gone up to almost 300, but there didn't seem to be any clear source of infection. So to cover for this, she was started on some antibiotics, acyclovir for her shingles, and some gentamicin as well, just to cover for sepsis, and then to await a rheumatology review. The rheumatologist came and tried to aspirate her swollen left wrist. However, this was unfortunately unsuccessful, and it's thought to be due to a lack of actual effusion within the joint. The neurologists were also called, and they found that she had muscle wasting within the small muscles of her hand. And at this point, she was convinced, due to her tingling and dysesthesia, that she thought she had some sort of demyelinating pathology, possibly CIDP, possibly because her neighbor at the time was also a neurology physiotherapist. However, they thought it wasn't typical for something such as CIDP, and it all pointed towards a mononeuritis multiplex. They organized a nerve conduction study, which the summary of the findings turned out to be, it could be mononeuritis multiplex, possibly due to a vasculitis or an amyloid, but also as well as any other cause of infection or inflammation as well. The main thing being that nerve conduction study ruled out was widespread demyelinating features, which were not seen. So to further investigate, a serial nerve biopsy was organized, as well as to look at other things such as Lyme serology, porphyria. So we were thinking it could be a paraneoplastic process, particularly given her history of persistent rays, CA125, as well as to also look at VEGF. And then a few days into her admission, she started to show signs of a systemic inflammatory response. Her temperature shot up, and it was very difficult to maintain her blood pressure, and her oxygen requirement also increased. we increased her, well, we treated her coagulopathy in anticipation of a nerve biopsy. And then we gave her some very strong antibiotics to cover for sepsis. And at the time, because we were worried about sepsis, we decided to delay the administration of any immunosuppressants such as methylpred. Interestingly enough, her hepatitis A also came back positive at the time, despite being negative only a few months ago. It was thought maybe this could be linked to her meal and her diarrhea. As she said, she had thought she'd eaten some gone-off fish, but we just weren't sure. And
when
yes,
I can hear you all right. I've had to turn my sound up to the maximum. There are one or two people in the audience who still don't seem to be able to hear you. So if you could just project as much as you can, and if everyone could turn their sound up if they're having trouble hearing, I think that might help.
Will do. Apologies.
Thank you. It's not. I don't think it's your fault. Okay.
So she desaturated whilst on high flow nasal oxygen, and she was then transferred to a level 2 bed for CPAP support. So looking at some of her investigations, comparing them from admission to a week onwards, this was her ECG showing sinus tachycardia with no real dynamic change, and this was done on admission. And now, pretty much a week later, you can see it's still showing sinus tachycardia. However, I just wanted to point out that she now seems to have a lower voltage of her QRS complexes, as well as lesser R-wave progression. And at this point, Dr. Mukhtar was thinking, could this be a sign that she may have some pericardial effusion? To add to this, a comparison of her chest x-rays from admission to a week later, and you can see she has quickly developed bilateral pleural effusions as well. Now, this could be due to the excess fluid that we were pumping into her to try and maintain her blood pressure when she was showing a systemic inflammatory response. However, taken in conjunction with the ECG changes as well, we're thinking, could this be a sign of serositis? Now, on intensive care, a whole variety of different teams and specialties came together to try and figure out what was going on. We sent some of the fluid in her abdominal vesicles, and this did show that it was varicella zoster. She developed hemoptysis whilst on intensive care, and with the help of her respiratory colleagues, a bronchoscopy was done, which showed a negative microarray, but found diffuse alveolar hemorrhage. So putting it all together, we were thinking rather than infection, especially since she didn't seem to be getting any clinically better on the antibiotics that we were giving and the other antimicrobials, could this be a multi-system, multi-organ inflammatory thing, something like vasculitis? So we very cautiously started some methylpred, and we up-titrated this gradually. During this time, coincidentally or not, she also developed a radial artery and brachial vein thromboses. This could be due to, while she was having the pulmonary hemorrhage, we didn't even give her any prophylactic anticoagulation just for fear of worsening the hemorrhage, and it could also have been line-induced, but now she had to be heparinized for these. She was switched initially to oral prednisolone as she gradually got better, and then she was finally discharged after a 15-day high dependency / ITU level stay and a 31-day hospital admission overall. And she was discharged with ongoing vasculitis and rheumatology follow-up with input from the cardiologists, the respiratory physicians, as well as the hepatologists as well. So to summarize this very prolonged series of symptoms and her presentation, she started off with polyarthralgia after her first COVID vaccine, followed by deranged LFTs, and then changes in her sensation, as well as weakness and muscle wasting as well, particularly in her hands and her feet. Then came the diarrhea and the shingles-like rash. Then came what we suspected to be pulmonary hemorrhage, possibly due to vasculitis. There was some microscopic proteinuria and hematuria, as well as pleural and pericardial effusions. And now we get to February of this year, and we have given her the the specialists have given her the very cautious diagnosis of polyarteritis nodosa with heart, lung, liver, nerve, and kidney involvement. At this point, following discharge, she had ongoing dysesthesia of her hands. However, she was able to walk short distances, and she was using a wheelchair outside the home, which, considering only a few months ago, she was reliant on CPAP in intensive care. This is quite remarkable. And she could almost be forgiven for having a little bit of shortness of breath upon climbing the stairs. She had persistent liver dysfunction with microscopic hematuria and proteinuria, and her CRP and platelets still remain slightly elevated. And she has been controlled on some prednisolone, which has been weaned down from a high dose. And she has had a few cycles now of cyclophosphamide, as well as being heparinized for her thromboses. And given the cautious diagnosis at the moment of polyarteritis nodosa, or PAN, I just wanted to go into how we would come towards that diagnosis and the way that the definition of PAN has changed as well. So considering the historical perspective, Virchow first in 1847, over 150 years ago, described a vasculitis which might occur in blood vessels originating in the outermost layer, in the adventitia of the vessels. And Rokitansky followed that up by noticing that there were mesoteric aneurysms in certain branch points of arteries in the autopsies that they were conducting. Kuspal and Meyer furthered this by noticing nodular thickening in countless different arteries that they saw. But it was only until 1907 when Dixon really established that it should be called polyarteritis nodosa rather than a periarteritis, signifying that the main point being the disease was happening with inflammation across the whole wall of the artery rather than just around it. This is the sort of medical textbook definition of polyarteritis nodosa. And as you can see, it's not very similar to our patient that we saw. So it's typically seen in a man. Certainly, often people can present with pain in the testicles. You can get a polyarthralgia and a mononeuritis multiplex, which we saw in our patient. However, lung involvement is usually rare, and you often get renal involvement, and you can also get skin involvement, which could be a whole different subset of PAN in itself. And there are lots of different diagnostic criteria as well, which have been developed through the years. And some of you might have heard of the American College of Rheumatology criteria, which is pretty much based on this diagram as well. It's a list of 10 points, which you should have at least 3 of which to make a diagnosis of PAN. And one of those is inclusive of testicular pain or tenderness. So considering all this and considering all the different diagnostic criteria and lists that people have made as well, we are going with the current definition of following on of taking it from the Chapel Hill consensus, which was first devised in 1993 and then revised in 2012. So this describes PAN as a necrotizing arteritis of medium-sized or small arteries without glomerulonephritis or vasculitis, without being in the microscopic vessels, and it is not associated with ANCA. Now, this is quite a key point, particularly with ANCA as well, because as time has gone on and as people have discovered things such as ANCA antibodies, the definitions has actually changed. And it's useful to think of PAN as possibly a diagnosis of exclusion within the vasculitides, especially as we discover more and more things that are associated with other types. So it seems like as the years go on, the diagnosis of PAN, the numbers of people that are diagnosed with PAN may gradually get to decrease as we recognize other vasculitides as separate entities in themselves. And now coming to this current group of PAN-like syndromes, we can see, as I mentioned, you have cutaneous PAN, which seems to affect only mostly the skin itself, and very rarely it can also go on to cause systemic symptoms. You have single organ vasculitis as well as specific monogenic or immune deficiencies, such as familial Mediterranean fever, which can cause a PAN-like syndrome. And of course, as I recently found out from revising from my exams as well, the classic exam question of someone with hepatitis B or hairy cell leukemia as well, developing polyarteritis nodosa-like symptoms. And we propose that potentially maybe the COVID-19 antigen or the COVID-19 vaccine, or maybe even hepatitis A, could be included in this. Maybe that it is directly involved in the inflammatory process of PAN itself, or perhaps it creates some other epigenetic predisposition to developing a PAN-like syndrome. And finally, just a word on the treatment of polyarteritis nodosa. It is very difficult given how rare the disease is. And this was one of the largest studies into looking at different lengths of cyclophosphamide pulses, durations of regime rather. And as you can see, even with it being one of the largest trials, we have numbers of n equals 6 in one cohort and n equals 12 in the other. So it is very, very difficult. And this trial itself was actually done in 2003. So things can only change as research progresses and as the actual definition becomes more narrowed down, more specific as time goes on. So before I open up questions to the floor, I would like to give particular thanks, first of all, to Dr. Mukhtar, who supervised me throughout this, and to Professor Jane, who helped us, particularly with defining a few more of the technicalities of polyarteritis nodosa and vasculitis, and of course to all the different teams who looked after this patient during her stay in the hospital. Thank you very much, and I will hand back over to the chair.
Thank you very much, Wen. What an interesting and difficult case. So it looks like you're left without a tissue diagnosis here, unless I missed it. If we hadn't had the difficulties of remote management of patients during the pandemic, do you think that her diagnostic pathway might have been slightly different, and would someone have considered biopsying something sooner, and if so, what would it have been? Dr. Mukhtar might want to get involved in that question.
I think overall, I mean, we did plan, well, the general consensus was that a liver and a renal biopsy would be particularly of use. However, towards the end of her admission, understandably, given the ordeal she'd been through, she just wanted to go home at that point. So I'm not quite sure what the sort of long-term plan is, but I'm sure biopsy is probably being considered at a later point. Given the pandemic as well, it's probably also highlighted the difficulties with remote reviews and not being able to examine patients as easily as before. And there were quite a few points in her history, particularly in the middle of last year, where she had real difficulty in seeing someone in person and being examined by the specialists as well. Yeah. So yes, I did think it did, so it may have contributed to her delaying her getting a diagnosis, but I think the overall picture was so complex that I'm not quite sure how much it would have done so.
Yeah, I mean, I think the thing I would add is that I mean, there was a plan initially to do a sural nerve biopsy, and that happened, but essentially that was non-diagnostic in any way, shape or form, and it missed the sort of relevant point, and that's the issue with biopsies in themselves. And then thereafter there was a plan for a liver biopsy, but every step of the way she seems to have developed an additional complicating factor, as you can probably tell from the summary slide. So by the time you've been through all of that and the prodrome that's lasted 10 or so months, it does become quite challenging to persuade people to do stuff.
Okay. Have you filled in a yellow card, given the strange association with the vaccine or not?
But there is a yellow card submission in process. I think the key thing is it does raise the question, is there an epigenetic phenomenon or that means that Hep C, Hep B, HIV can extend to including COVID-19 potentially, and or COVID-19 vaccines. So, yeah.
Okay, and a question has been raised in the chat about vascular imaging to diagnose polyarteritis, which I can see that David Jane has already started to answer. David, do you just want to say a word about this?
Yes, thanks, Fiona. If there's a specific reason, like we're suspecting some sort of intra-abdominal hemorrhage, then we might do an angiogram. But essentially, blind angiograms in a patient with inflammation like this, you never see aneurysms. So we're rather moving away from using the word nodosa. This is very much a bucket. We tend to prefer the word polyarteritis.
Okay, thank you very much. So who will be her primary team in secondary care going forward? And what does the future hold for her, do you think?
She's currently under the vasculitis team. I think David is leading her care at the moment. And yeah, that's probably the best thing for her.
So she completed her 6th cyclophosphamide infusion last week, and we've converted her to mycophenolate. She's not completely out of the woods there, though liver dysfunction remains a bit of an issue, which we're continuing to discuss with hepatology. And as you pointed out in your opening question, Fiona, in the absence of convincing histology or radiology, there's always an uncertainty about this diagnosis. She did respond very well to steroids, which you often see in naive cases of polyarteritis, but they tend to become progressively more steroid resistant, which is why you need second-line drugs.
Great, thank you very much. And Nick has asked another question as to what extent the diagnostic label alters the management plan.
Well, I think this is what's so confusing if you look at the literature, because these words are used by different people to mean different things.
Yes.
And when I was studying for the membership, at the bottom of every differential diagnosis was PAN. And I think the slide that Wenshu showed of the way we approach diagnosis in vasculitis, where we pick off the more clearly defined syndromes, and then we're left with a less clearly defined group of syndromes at the bottom. Interestingly, some are definitely monogenic disorders, which there is some progress with. And I think this has been a neglected area in vasculitis research, which is now beginning to receive a little bit more attention.
And yeah. Are there any other questions either that people want to unmute themselves to ask or put in the chat? It sounds as though this lady has a lot of life changes to get used to.
Indeed, yes.
Okay, I can't see any other questions. And it is almost 2, in which case, may I thank both our speakers for excellent presentations, and thanks to all of you for great questions, and hope that you will all wish to come again at 1 o'clock next week. Thanks, everybody.
Thank you.